Hello, welcome to the toxicology section for Apollo Med Flight's orientation. Um, my name is Damon Crabtree. I'm the lead field training officer and a flight paramedic. You can reach me via email if you have any questions or if I say anything wrong in this PowerPoint, you think I should fix it, go ahead, shoot me an email. You can also reach me by phone, 806-206-8015. I'm available around the clock for calls or text. If you ever need help with anything, if you have a question about our protocols or any education needs you might come up with, just let me know. So this lecture, we're going to discuss different types of toxicological emergencies, so our different toxidromes. We're going to briefly discuss each one and what their management is. Our main ones, we're going to look at some, toxic alcohols, aspirin, Tylenol, TCAs, also your cholinergic, anticholinergics, and pathomimetic issues. So as always, it's going to be safety first. For the flight environment, we shouldn't be showing up to scenes too often. It might happen on the helicopter, but that's not our gig. We're not there for hazmat and decontamination. Somebody should be providing those treatments and procedures prior to our patient contact. But just remember, wear your PPE. If you're worried about something, wear a mask, wear a face shield, make sure you always have your gloves on you. Your flight suit's also part of your PPE and helps keep contaminants off you. Just because they've been through hazmat decontamination doesn't mean it was always perfect. So be cautious when removing further clothing. If for some reason they had clothing on still, of anything that could be in their pockets, be it needles, additional drug, that sort of thing. If you do show up to a scene, make sure you read your environment. So smell any visual signs of gaseous mixtures or liquids, any hazmat symbols that could kind of clue you in that something dangerous may be around. And then we always kind of have to worry about explosions, and then our patients acting aggressive, either be because they're aggressive for just whatever reason, or whatever they've been exposed to is causing them to have those symptoms. For our assessment, any toxicological issue, we're going to need to assess the airway well before we put them into the aircraft. So top priority is going to be airway assessment, and then we're going to have to pre-plan. So if they're having any airway, contamination where they have, swelling of the airway, chemical reactions where they're having adventitious lung sounds, they have stridor, difficulty breathing, that sort of thing. Obviously, we're just going to go ahead and perform RSI and get that factor out. But we also have to be cautious of latent effects. So if somebody overdoses on a handful of clonidine, well, at first, everything's going to appear normal, and then, heart rate, blood pressure is going to drop, mental status is going to change, and then all of a sudden you have a patient that's crashing on you, an hour and a half into it. So if we show up really early, we have to perceive that there's going to be some sort of hemodynamic compromise, and we might just want to do it safely on scene instead of trying to perform an airway or get additional IVs in flight. When it comes to breathing, we're just going to need to assess, what kind of ventilation they're doing. And a lot of these toxidromes, it's going to be kind of an acidotic type chemical. And so for these patients with, metabolic acidosis due to an overdose, they're going to have extremely high minute ventilation. And that's because their body's trying to do this respiratory alkalosis in order to compensate for the metabolic side. So if we do proceed with intubation in a patient with, say, like an aspirin overdose who's kind of breathing like a DKA patient with Kussmaul, we would need to be mindful of setting our vent settings to continue to do that respiratory alkalosis. Depending on how long the ingestion's been, if you intubated, a patient with some acidosis due to an overdose, at first, you might get, easy vent settings where they're pretty normal tidal volumes, relatively normal amount of ventilation. But as their body starts to process that chemical, you might have to keep going up and change your vent settings as necessary for how they progress in their exposure. Circulation, you'd want to get a nice baseline for cardiovascular status, and then you want to really predict where they're going to be at, during your transport. So if you think that they're going to have a vascular collapse due to a beta blocker overdose or calcium channel blocker overdose during flight, we'd want to get those treatment measures on board. Maybe we'd want to get invasive monitoring so we can get those really low blood pressures if they start to crash on us, and really pre-plan for something bad happening. The reason this happens is some agents are just directly cardiotoxic, and some are, vasoactive, where they vasodilate somebody substantially. Also, some of them are going to redistribute fluid to the, intervascular or the third spacing, or maybe it's going to just eliminate fluid from your body. They're going to hold on to too much fluid. There could be several combinations that happen. Electrolyte disturbances, so like in your beta blocker, calcium channel blocker overdose, they're going to have issues with calcium, and it's going to cause dysfunction of the heart due to that hypocalcemia. They might have some altered oxygen carrying capacity, so like in a carbon monoxide or any other sort of hemoglobin attacking agent, then they just might be, hypoxic at the cellular level because they can't get oxygen to the cells. And then always, if it's like a narcotic overdose, if they get apneic, eventually that's going to cause hypoxia and arrest. So getting a really good history of event, knowing which substances were involved, and if there's multiple ones, how much of each dose, and at what point did they take the dose, so time, quantity of each drug, and then try to estimate what that duration of exposure is. If you have the ability, call in poison control, can answer some of those questions that we're just not familiar with because we don't get to do toxicology 24/7. We want to know what route they were exposed. So like with the newer types of fentanyl that are coming on the street, some people were crazy enough to, try to smoke fentanyl. A lot of times they're injecting it. So did they get into an IV or a vein, or did they accidentally puncture an artery? Did they try to do it IM? Did they dry it out? Did they sniff it? Figure out what that route of exposure, because we're going to be able to predict more precisely how long that's going to be in their system or how quickly those symptoms are going to onset. We'll want to get an initial presentation, and then we'll have to judge that. So if we show up with EMS and they're saying, hey, they were GCS of 15 5 minutes ago, and now they're GCS of 13 or 12, and it's dropping, then we would know, hey, we rapidly need to take this airway and start reversal measures if they're possible, because this patient's beginning to trend downward. Always make sure we have them decontaminated, stabilized as best we can with fluids, intubation, starting a vasopressor as necessary, and then doing that whatever our reversal agent is. Your prodromal symptoms, so your symptoms that happen before peak effect. So that's what's going to clue us into like undifferentiated tox patient. So if they show up with, vomiting, diarrhea, sweating, all this, well, then that sounds, more like an anticholinergic agent, and so we know how to go that pathway even if a patient or bystanders can't tell us. So those are pretty important on learning which toxidrome it is. Then obviously any medical history, comorbidities, last meds taken, and any allergies they might have. Vital sign, a couple of things that we're going to clue you into which toxidrome you're dealing with. If they're bradycardic, it might be due to an ethanol, benzos, clonidine, anything that's like a cardiac glycoside, so your organophosphates, digoxin or carbamates, which is kind of like an organophosphate as well. Calcium channel blockers and beta blockers obviously going to have a direct cardiac effect. TCAs end up having cardiac effects, and then some household poisoning like chlorine gas, and that sort of deal. Also, in the CNS depressants for bradycardia, you'd have to throw in like heroin or narcotic overdose. And then tachycardia, those are going to be more with your sympathomimetics, so caffeine, amphetamine, methamphetamines, cocaine, Benadryl can have those sort of effects as well. Anticholinergic, atropine, TCAs can have drying effects. Your antihistamines are going to cause drying effects as well. And then your cellular hypoxic agents. So if it's carbon monoxide, they're probably going to be tachycardic because their body's trying to get that oxygen out to the cellular level. Your temperature, some of these agents are going to make it difficult for thermal regulation. So either they can get really hot or they can get really cold. If they're hyperthermic, they're more prone to seizure type activity. It's also going to be present in hypermetabolic states. So an aspirin overdose, they're probably going to get hot because they're breathing, and they're trying to get rid of the drug and they just can't do it. Hypothermia, so a lot of these can be combined with outside temperature. So alcohol with a homeless person is usually the most common, where they're drinking alcohol, they feel warm, and so they don't bundle up as much, or they take PCP, and everybody on PCP, no matter what the temperature is, likes to take their clothes off because they have hyperthermia. So they might be hot, and then they take all their clothes off, and they're outside for who knows how long, and they start dropping their temperature. Same thing with narcotics. They might just not notice how cold they are. As they vasodilate, so if it's a calcium channel blocker overdose, well, you're going to vasodilate and you're going to lose a lot of heat from that vasodilation. Narcotics, clonidine, alcohol is going to impair your shivering response, and then sometimes your metabolism is going to be impaired. You could have hypotension due to fluid loss, third spacing, and then that vasodilation. And then hypertension, that would be with like our sympathomimetic, anticholinergics, or if you just had too much norepi or phenylephrine on board from a possible overdose. So different toxidromes. So that's a classic chemical that causes a pattern of symptoms. So we can kind of group them together. Your first one's going to be anticholinergic. So your anticholinergic medication, the most common that we deal with is going to be atropine, since that's a medication that we happen to give. Your antihistamines, TCAs, bentropine, all have these effects that are going to kind of act the same. What it does, it's a muscarinic receptor blockade. The little saying is blind as a bat, hot as a hair, dry as a bone, red as a beet, mad as a hatter. So mydriasis is your dilated pupils. They'd have blurred vision, fever, flushed skin. Just like, given atropine, it's going to dry up a patient. They're going to have some psychosis and coma, possibly some seizures. Ileus is just your bowel not moving. Urinary retention, they're going to be hypertensive and tachycardic. So how do we manage it? So obviously we're going to do ABCs. We're going to control the airway if they need controlling. If they're having a seizure, they have altered mental status, we suspect that's going to happen. We'd want to control that airway. Benzodiazepine is going to kind of help, include any seizures, but it's also going to knock down that heart rate, that blood pressure, and maybe stabilize them a little bit better. There's a specific antidote for all these agents, and it's physostigmine. It just has some contraindication. So if they have an abnormal EKG, then we might want to be cautious with the physostigmine. If they have a history of seizures, and then if they have co-ingestions of other drugs like TCAs, they're going to have problems with the EKG at baseline. Then you got your cholinergic. So this is just going to be the opposite of the anticholinergics. So what's opposite of atropine? It's going to be the organophosphates and nerve agents, because they're going to cause everything that we would be giving atropine to treat. So your dumbbells is your mnemonic. So it just makes them really wet. So they're diaphoretic, they have diarrhea, they're urinating. Meiosis is constriction of the pupils, bronchorrhea, so they're just pouring fluid. Instead of tachycardia, these are going to have bradycardia. These are going to have decreased blood pressure. They're vomiting. They're going to have excited muscles and lacrimation, so they're going to be crying, and then salivation. So it's like your sludge where they're just pouring fluid from everywhere. That's going to be your common cholinergic agents. We're going to support ABCs like always. These patients are going to be really sick, so intubating them is probably not going to be that big of an issue because they're probably going to need it. They're going to get high doses of atropine. 1, 2, 4, 6. You're just going to amp up that dose every time. If you happen to have 2-PAM, which most people, like most ambulances still have them due to WMD policies, but those aren't to give to the patient. Those are simply for the people on the ambulance. So this would be something that maybe the hospital that would have a hold of to help out this patient. It needs to happen early because if they make it to the phosphorylation, the patient's not going to recover, and this 2-PAM is not going to do anything for us. Your sympathomimetic or your adreneric toxidrome. This is going to be anything that increases our sympathetic system. So cocaine, ecstasy, amphetamines, PCP, ephedrine or pseudoephedrine could do it, and then caffeine. If they overdose on a large amount of caffeine, they're also going to show these same symptoms. So increased temperature, tachycardia, hypertension, dilated pupils, and seizures, nausea, vomiting, diaphoresis. So kind of similar to our cholinergic type patients, present sort of the same way. So make sure that we get a good idea of what they took. So most of the time it's going to be illegal drugs, but it could be some over-the-counter stuff that they run into. So our management do ABCs like always. In the hospital, they could do, assess for some co-ingestion. So look for Tylenol and aspirin overdose. They're going to check all the electrolytes, make sure they're not hypernatremic, hyponatremic. Check a CK level for rhabdo because, especially in a PCP patient, they're going to be going crazy and using up the muscle, and it's going to burn through that muscle and possibly cause the rhabdo. So, CK greater than 20,000, T-colored urine is what we'd be looking for that. Looking for a CT of the head, looking for any bleeding that might be causing the symptoms, or see if, because of their condition, they have, popped an aneurysm or something in their head. Check your cardiac biomarkers. Best thing we can do, so like for a cocaine overdose, is give benzodiazepines and try to get the body to calm down a little bit. Try to keep them cool. They're going to be usually pretty hot. That's why your PCP patient takes off all their clothes, is because their thermoregulation is just off course. And then after that, if you give a bunch of benzodiazepines and that doesn't get their blood pressure down, you can start controlling blood pressure. Nitroglycerin probably would be my go-to. Nitroprusside is extremely unpredictable, not the best agent. And then labetalol is a little bit of an issue if it's just from this adrenergic toxidrome. It's usually contraindication indicated to give beta blockers. If you have to give any beta blocker, labetalol is probably the way to go. But possibly considering a calcium channel blocker, so like a nicardipine might be something suitable to bring the blood pressure down if, say, nitroglycerin wasn't able to control it. And then you got your narcotic, which everybody should be pretty comfortable with. They're going to get cold. It's going to vasodilate them, and they're going to get bradycardic, so it's just going to lose all their temp from that vasodilation. It's going to cause hypotension due to that. They're going to get bradycardic because their body thinks nothing's going on in the world, because it's going to block all their epi and norepi from responding to it. Respiratory depression, that's obvious. They're going to have the constricted pupils just like any narc overdose, and then they're going to have altered mental status. For management for that, everybody should know. We're going to do ABCs, and then we're going to give Narcan. For Narcan, I can't tell people enough, don't give 2 milligrams IV push. That has a huge potential for the patient to wake up, vomit, and start to fight you. The dose I give is I'll just take a vial of 0.4 milligrams. I'll draw that back into a 10 cc flush, and then I'll give a cc, so 0.04 milligrams every 30 to 60 seconds until their respiratory rate is adequate. After that, I just let them be, altered as long as they're breathing and they have good intitals and pulse ox. And then if their respiratory rate starts to drop down again, then you just give a little bit more. Some people might start infusions. I think for what we do, just that IV bolus whenever the respiratory rate starts to drop off is adequate enough. Just know naloxone has a short half-life compared to most of the opioids, especially your long-acting, oral narcotics that people have been prescribed for years. So if you give them Narcan and they wake right up, they need to be monitored for a while until that's out of their system. With Narcan, especially at that 2 milligram dose and on repeated doses, could cause pulmonary edema and seizures. So please just be mindful of that and give just the lowest amount that you need to get them to start breathing. Don't try to wake them up. So there's a couple syndromes that happen due to medications. So obviously, malignant hyperthermia is a common one for anesthesia. So people that are doing day surgery or in the hospital surgery, given succinylcholine all the time, might run into this malignant hyperthermia. What happens? You're going to have muscle rigidity. They're going to get really acidotic. They're going to get extremely hot. Cue the hyperthermia. Tachycardia, tachypnea, and quickly the potassium is going to rise and they're going to develop rhabdo if not treated immediately. So the treatment for that is aggressive cooling, correcting acidosis, if that's through a bicarb drip and turning up your respiratory rate really high on the vent to blow off as much acid as you can. And then the true reversal is going to be the dantrolene, which isn't available to us unless the hospital somewhere gives it to us to administer. Neuroleptic malignant syndrome. So that's happening with some of our anti-psychotic medications. So how the all-encompassing could be from Phenergan or Risperdal that a lot of psych patients are on. Your symptoms are going to also get really hot. They're going to have muscle rigidity. They're going to be acidotic. They're going to have coma or confusion. And then that could precede renal failure, and then arrhythmias due to renal failure and cardiovascular collapse. Treatment for that is just going to be aggressive cooling measures again, and then giving them muscle relaxants, considering dantrolene, and then benzos. Serotonin syndrome. So this could happen just with the patient taking SSRIs. That's going to be the most common medications for depression and bipolar. Your selective serotonin reuptake inhibitors could happen from SNRIs, so serotonin norepinephrine reuptake inhibitors, just another class of medications. Could just be their normal dose. So it doesn't mean that they always overdose on it. So what's happening there is they're going to have increased respirations, their heart rate's going to increase, temp's going to increase, and they're going to be really wet usually. So their skin's going to be flushed, they're going to start sweating. They might be total body dry, so they might lose some fluid. They might keep some fluid, too much fluid on, like an SIADH, so that would cause hyponatremia. And it's kind of unpredictable. We have several different agents because I know with ecstasy, those patients are going to get really dry. So at first they're going to sweat a whole bunch, and they're going to lose a lot of fluid, and then they're going to be dry, kind of like an atropine overdose would be like. So there's a whole bunch of different symptoms. Myoclonus, is one of the higher ones. That hyperreflexia. Confusion is going to happen half of the time, but everything else is just kind of sporadic. So what we're doing, ABCs like always. If they're taking their SSRI and they've just been taking normal dose, you'd want to stop that because the sooner you stop it, the sooner it'll wear off. You can always consider gastric lavage and activated charcoal. We'll get into that in a bit. I have some strong opinions on that. Because of the tachycardia and the increased respiratory rate, benzodiazepines are indicated for the reversal of that kind of thing. And then the other drugs just don't necessarily have a lot of evidence that they help. So diphenhydramine, chlorpromazine, stuff like that. You're probably not going to run into it unless a physician is requesting that it be given. It's mainly supportive care and possible benzodiazepines. So move on to our activated charcoal. So I came into medicine where activated charcoal was starting to come out of practice. It does still have a place for these tox patients, but it's not given to everybody. So what it does is hopefully it's going to absorb any agent that's in the stomach still. So just a small amount of area. So 50 grams of activated charcoal could spread over 10 football fields. So it's really going to bind anything that's still in the stomach. There's a little bit of a risk. I think everybody probably has had experience with that. There's a risk of aspiration. So these patients are altered. They have whatever symptoms that's causing them to present to, you in the helicopter, you in the fixed wing, or to whatever hospital they showed up to. So if we give an altered patient this, drug, they have a high risk of throwing up and aspirating it. So if it's a severe overdose, before you get back to your charcoal, you'd want to control the airway first. Your dose is 1 gram per kilogram. Alcohols and heavy metals, it doesn't do anything. And a lot of times, if they're beyond 1 hour, there's really no reason to give it. The only reason to give it beyond 1 hour is if it's something that, has a very, very long absorption time. So, like the long-acting narcotics that they've given. So the hydrocodone combinations that are supposed to last for 12 hours. Well, in a hydrocodone overdose, they're going to have, ileus, where their bowel's not really going to be moving too much. So it might extend beyond 1 hour because they're just not moving that through their stomach. So it might have use in patients that have poor GI motility. So what isn't absorbed? So kind of your heavy metals, iron, lithium is going to be a problem. Cyanide's not going to do anything for. Some strong acids. So if they took much hydrochloric acid somehow, or sodium hydroxide, and then simple alcohols such as ethanol, methanol. Activated charcoal doesn't have a place for those. I kind of already said when to use it. If it's less than an hour from ingestion, it's something to consider along with gastric lavage, but obviously we're not going to be driving that. We don't carry activated charcoal. That's something we want to consult a physician on scene at the hospital about doing, or maybe get a hold of poison control and an actual toxicologist for recommendations on what to do. Most toxic substances, they're probably not going to show up within the first hour unless they just took it outside of the ED door. And then the question is, are we even going to show up in time? So you might show up where this is already been given, then we'd want to monitor for aspirations. But this isn't given routinely anymore. Every patient's not given it. We don't carry it on the ambulances for the most part. So it's going to be very uncommon that it's used. Different drugs that have to be removed through dialysis for some extracorporeal measure. For hemodialysis, that could be your methanol, ethylene glycol, aspirin, lithium. Hemofiltration would be procainamide or methotrexate, and then some hemoperfusion, theophylline, aminoglycosides, phenytoin, sotalol, that sort of idea. So this is kind of the end goal for these types of drugs, is we'd want to manage them from regional hospital or scene to a hospital that has this treatment measure. Patients that we're going to want to do urine alkalization, so given, sodium bicarb would be like fluoride poisoning, your aspirin, barbiturates, methotrexate, that sort of deal. All that is just given bicarb essentially. So different types of ingestions. So Tylenol is fairly common way to overdose in the United States. Even if a patient doesn't intend to overdose, it's very easy to overdose on Tylenol and not mean to. So your peak plasma is going to be less than an hour. So it gets converted pretty quickly and peaks early on. Obviously, it's metabolized in the liver. The toxic metabolite that it makes is this NAPQ1. It binds to the specific cells in the liver and causes direct necrosis. So our toxic thresholds of 7 to 10 grams roughly. So that would be, 15 to 20 500 milligram pills. So pretty easy to overdose. Most recommendations is having less than 4 grams in a 24-hour period. So if somebody's right at that 4-gram mark every day for days on end, they could start developing these same symptoms. So you have 4 different phases. Phase 1, they're not going to eat a lot. They're going to get anorexic. They're going to be real tired, some nausea, vomiting, and they're going to get really diaphoretic. Phase 2, you're going to start having liver pain, so right upper quadrant pain. Your liver labs are going to increase, and then you're going to lose some of the symptoms that you had from phase 1. That's going to be day 2, so 24 to 48 hours. So day 3 and day 4, so phase 3, you're going to have true liver failure. That could cause you to develop encephalopathy. They could get coagulopathic, decrease your bowel sounds. Due to the liver failure, that could cause pancreatitis. Due to the liver failure, that could also back up into the kidneys and cause acute renal failure. And then if they make to phase 4, they're either going to die or recovery. So they're either going to recover from it or they're going to need transplant to recover from it. And that's just the gist of aspirin overdoses. Your treatment. So due to a little bit decreased GI motility, especially if it's combined with a narcotic, activated charcoal could be given out a little bit beyond 1 or 2 hours. Gastric lavage is probably a decent idea to go along with it. And that's just going to absorb, some of the medication. So hopefully it decreases their symptoms and maybe they end up surviving. Your different alcohols. So you have ethylene glycol, which you should just think as a like antifreeze is what ethylene glycol is. So somebody chugs a bunch of antifreeze, they're going to have a toxic alcohol. Your methanols, so, and then the isopropanol or isopropyl alcohol. These labs are going to have a huge anion gap, metabolic acidosis. Symptoms could be delayed if they were drinking. So if they were drinking ethanol, so just a regular alcohol, that's the treatment for ethylene glycol overdose. So it might counteract part of that if they're also taking ethanol. What can happen? So big thing is this hypocalcemia. Hypocalcemia is going to cause myocardial dysfunction. And if you don't replace that calcium, because if they have hypocalcemia, the heart's just going to stop beating very strong. So eventually that's going to cause cardiac arrest. Just 100 milliliters could be lethal, so that's not very much fluid to cause death. Your different phases, so 30 minutes to the first 12 hours, they could just appear inebriated, all over the place with respirations. They could have seizures. Obviously, the hypocalcemia, they could develop crystals in their urine or cerebral edema. Phase 2, so 12 to 24 hours, that's where you're going to have a lot of that myocardial dysfunction, congestive heart failure due to that. And then phase 3, acute renal failure, then that's 2 to 3 days out. Methanol, 150 to 240 mils is a lethal dose. That's going to show up with headaches, inebriation, dizziness, vision loss, pancreatitis. Ethanol is the treatment for methanol. So what we're going to do is we're going to want to try to counteract that methanol and then get them to dialysis. Isopropanol, that's going to cause ketonuria, might not have an anion gap acidosis, or they might have metabolic acidosis, one or the other. They could develop hemorrhagic gastritis, so pouring blood into their gut. And then it's just going to be supportive care while they burn through that. So if you increase your respiratory rate, it's going to help blow off more of that acetone, and dialysis if they got a huge dose. Your aspirin overdose, so lethal dose for that's 10 to 30 grams, so a decent handful of aspirin. Those symptoms, tinnitus is one of the hallmark ones, fever, vertigo, nausea, vomiting, diarrhea. They're going to be acidotic because aspirin is an acid. So they're going to be breathing, 30, 40, 50 times a minute. And if we put them onto the vent, we'd want to continue that to continue the respiratory alkalosis, because they're going to get profoundly acidotic. So we'd want to do the most we can to try to keep the CO2 low. So ideally in the hospital, 2 hours, we'd want to check the level until it starts to decrease twice. Then we know that when our peak effect happened, and we can start estimating how long this aspirin is going to be in their system. Activated charcoal might be useful if it's within a decent time period. They might need some glucose because they're just going to be burning through it. Alkalizing them with sodium bicarb and getting their pH up high, and then doing dialysis as needed. So any sick one, so anybody that we're going to intubate and that has compromised lab values is probably going to get hemodialyzed. TCAs, so amitriptyline would be a pretty common TCA to overdose on, because people that receive amitriptyline are probably depressed, and then now they have this great drug to attempt to kill themselves with. Peak dose 2 to 8 hours, half-life 24 to 72. So it could be particularly lethal. So what's going to happen is it's a sodium channel blocker. So it's going to slow your depolarization. It's going to widen your QRS. It's going to cause, VTAC or possibly torsades, and that's going to cause them to become hypotensive, decrease their cardiac output. They're going to get coma. They're going to possibly have seizures, and then they're going to kind of act like an anticholinergic, where they have high temps or flush, dilated pupils, sinus tachycardia. Treatment for this, activate charcoal. Unless they did it in front of you, probably not going to have a use. Gastric decontamination, if it's past the pylorus, it's probably not going to do anything for you. The best thing you can do is give all the sodium bicarb you have. Most case studies are going to show that 8, 10, 15 amps of bicarb is indicated, and they need it in order to decrease their QRS duration and hopefully stop any seizure activity from happening. So you're going to pretty much use all your bicarb up on these TCA overdoses. Dialysis isn't going to do anything, and if they start having seizures, we want to avoid Dilantin because it's also a sodium channel blocker. Beta blocker overdose, so they'll begin symptoms within about 4 hours of ingestion. If they didn't take too much, after about 6 hours, it's starting to lose that peak effect, and they're probably going to be just fine. So if it's been a little while and they don't have symptoms yet, they're probably not going to develop symptoms. Possible symptoms that could develop: hypotension, obviously, bradycardia, different blocks that could cause congestive heart failure. Because it's a beta blocker, they could have bronchospasm, and then seizure, coma, altered level of consciousness. Treatment: activate charcoal within an hour. Usually not going to happen. Transvenous pacing is probably the best thing that can happen for this patient if they need to be paced. But all we can do in the field is going to be external pacing, and it may or may not have good capture. Glucagon is the alleged antidote. There's questionable studies out there that don't know if it really works. If it's going to work, it needs to be given early, and it needs to be given at a very high dose, so 5 to 10 milligrams, so a whole lot of glucagon. The best thing that can be done for the patient is start an insulin drip, and so these patients aren't going to get standard insulin drips, at like 0.1 unit per kilogram. These patients are going to get like high insulin drips, like 1 unit per kilogram, so 70 units IV an hour potentially. Extremely high due to what's going on with the cardiac myocytes, where they're not contracting well. Insulin is a very good chronotropic and inotropic agent, and so it's going to help them recover from that. And also the beta blockades cause some issues with calcium, and insulin helps calcium move more effectively. That's where it gets its inotropic effects. Obviously, calcium channel blocker, it's going to be kind of the same idea. The difference between beta blocker and calcium channel blocker is beta blocker is more likely to produce seizure, coma, altered mental status. Calcium channel blocker is going to have most profound effect on blood pressure. So this can cause them to be very hypotensive. It also can cause bradycardia, maybe not as much as the beta blocker. And then some patients still might have that confusion, but less so than the beta blocker treatment. You could give charcoal if you needed. Obviously, we're going to do ABC, start a pressor to segue them to a definitive treatment. Calcium chloride or calcium gluconate is very appropriate, but doesn't work very well. Again, what they need is this insulin glucose infusion, high level insulin infusion, and then the glucose is just to counteract that insulin infusion. Carbon monoxide poisoning, obviously smoke inhalation is the main cause for carbon monoxide. So that's where we're going to see it the most. So it binds 240 times more than O2 to the hemoglobin, causes tissue hypoxia because it causes a left shift on the oxyhemoglobin dissociation curve. So the oxygen, if it's there, might get to the cell, but the hemoglobin won't let go of it. Patients might have normal carboxyhemoglobin levels, 5 to 10% in smokers, or if they were in Beijing where they have horrible smog, they might just be walking around baseline with a lot of carbon monoxide. 5 to 10 is not really that big of a deal. That's just gonna be what a smoker walks around acting like, where they're gonna have headaches when they don't, when they think that they're not smoking, they might need another cigarette because they have a headache, and then some difficulty breathing. It's beyond 10 that we start worrying about it. I see a lot of people use the cutoff of 15 needs treatment. So 10 to 30%, that's where you can develop weakness, dizziness, nausea, vomiting, difficulty breathing, maybe some ischemia due to the hypoxia. So everybody immediately just gets 15 liters a minute until we figure out what's going on. If over 50% of their hemoglobin is saturated with carbon monoxide, that's where they're going to develop coma, seizures, death. And people that do survive, 10 to 30% are going to have symptoms for the rest of their life. So diagnosis, hospitals should have a co-oximeter that's going to actually just read the pulse and give you what the carbon monoxide level. Newer LifePak 15s and some of the new Zols just come with it built into the pulse ox. Remember, pulse ox isn't going to do anything because all it does is just going to read if that hemoglobin is bound. If it's bound by carbon monoxide or by oxygen, it can't differentiate between the two with standard pulse ox. So we're going to give high flow oxygen, and they need hyperbaric in order to get that carbon monoxide off of the hemoglobin. So just remember, you can find a list like this online, and this is just going to tell you what the specific antidotes are for different agents. Some of the less common ones, so methemoglobinemia, they get methylene blue. Methylene blue is also an agent used for, hypotension that's unresponsive to anything else. Benzodiazepines, supposed to be romazicon as an antidote. Pretty much we don't give romazicon anymore. We still carry it, but it has a high propensity for seizures, especially in a child. But even adults, it's not going to do anything for you. Just intubate them and do supportive measures and get them through that overdose. Amyl nitrate, sodium nitrate, thiosulfate, or hydroxycobalamin are going to be your agents for cyanide. So most smoke inhalations, if they're severe and say they're intubated, should probably receive all those antidotes for cyanide poisoning because of the type of material in houses. Most carbon monoxide poisonings are going to have a cyanide poisoning as well. Digoxin is going to have digibind. Besides that, everything is just something you can find online. If you happen to run like an iron overdose, we're not going to carry deferoxamine, but the hospital might be able to give it to you. So that concludes the toxicology section. I'm not an expert on toxicology, so if I said something wrong, please let me know. If there's anything we can do to improve these lectures, send me or Ducey an email and we'll get that changed. If you have any questions, let me know. I might not have the answer, but I can point you to the right resources to find the answer. So thank you very much. Have a great day.